Let's maybe take a few quick scenarios. What about a patient that had a 7 centimeter extremity tumor resected from outside, comes to you with pathology of a sarcoma? How do you look at that patient? What are some of your initial thoughts when you go to a tumor board?
I think the important thing for that patient would be margins. What are the margins? Are the margins negative? Do we need to go in and resect again? Do we need to do radiation therapy and adjuvant chemotherapy? So all of that stuff is important, but the pathology review, again, comes in first for the margins.
Yeah, and you need to know the grade of the tumor. So margins are important. You also need to know the grade of the tumor. For a low-grade, well-differentiated liposarcoma that has a positive margin, you may be able to just watch that, as opposed to a high-grade tumor where you're going to want to do a tumor bed resection and certainly consider some form of adjuvant therapy.
Yeah, and I agree, and a lot of it is also, what did the surgeons know going in? Did they know that this was an oncological procedure, and did they do a proper procedure, or was this something that they felt it was just a benign lesion and came out because that re-resection could be critical? But what about a tumor that has a 10 centimeter high-grade extremity lesion? I know there's a lot of controversy in our field about neoadjuvant therapy versus adjuvant therapy, and what do you use? And John, why don't you tell us a little bit about your approach?
Sure. At Sylvester, when we see a patient with a high-grade, large, particularly bigger, larger than 5 centimeter high-grade sarcoma, we generally have the approach of multimodality therapy. So at tumor board, we discuss chemotherapy, surgery, and we discuss radiation. The sequencing is where it's important to rely on the expertise of the other physicians. For instance, if a tumor is very close to a nerve and another couple of weeks of growth could result in an amputation, you don't want to do that. Maybe surgery first would be a good approach. But in general, for this specific scenario, at Sylvester, we would do preoperative chemotherapy, 2 cycles, reimage with another MRI. Stable or responding, we would continue with another 2 cycles. Patient would have preoperative radiation, surgery, and then quite likely additional chemotherapy post-operatively to complete 5 to 6. Generally, we shoot for 6 cycles of doxorubicin plus ifosfamide. There's limited data, as we all know, on neoadjuvant, but there's pretty good data supporting adjuvant chemotherapy in the setting of a large high-grade sarcoma based on the meta-analysis. Yeah. And so what we do is we just move a portion of that adjuvant chemotherapy preoperatively. Yeah. It helps us also understand the sensitivity of the individual patient's tumor to that chemotherapy, so you can really design a personalized approach.
Does everyone agree with doxorubicin and ifosfamide versus?
Well, it depends on the age of the patient, right? So if the patient is older, ifosfamide will be a little bit difficult. And I've been using atramycin with olaratumab neoadjuvantly, even though it's been approved for metastatic setting. But patients who are over the age of 65, it's difficult to use ifosfamide for them.
So what are your thoughts about the Italian-Spanish study where that came out a couple years ago, showing basically equal efficacy of 3 cycles versus 5 cycles of AIM in the adjuvant setting? Is it because they're both equally effective or equally ineffective in the neoadjuvant setting? I think probably more likely that they're equally effective to a certain degree. But do you need to give 6 cycles, particularly with a drug that has such long-term side effects? Is it worth giving that potential and actually losing your ability to treat them later on if they metastasize with doxorubicin?
Yeah, it's a tough question. I mean, because one of the things you're wondering in that situation, are you treating for overall survival? My experience sometime with AIM-2 is you only see your best responses after about 4 cycles of the therapy. So it depends what you're trying to do with the treatment. Are we trying to surgically convert a patient or really shrink it, or are we also trying to get to survival? And I think it's important to manage patients' expectations as well. And Rich, what do you approach, or how do you approach a patient like this?
So if I can, well, I'll sort of just to back up, we've heard about John and Kristen use chemotherapy. At Duke, we actually fall on the complete other side of the spectrum. So for the scenario that you presented, a large high-grade extremity sarcoma, we would take the tact of a neoadjuvant therapy, not chemotherapy, but rather radiation therapy for about 5.5 weeks, followed by resection. And at least at our institution, the use of adjuvant chemotherapy is used rarely, to be quite honest. The data that supports the use of adjuvant chemotherapy, there's a suggestion through subgroup analyses that large high-grade extremity sarcomas are the ones that are most likely to benefit. We know that there's been recent published data that showed, John quoted the meta-analysis. The meta-analysis showed improvement in local and distant recurrence-free survival, a trend towards overall survival. More recent randomized data showed absolutely no improvement for relapse-free or overall survival. So I think it's still an area that's controversial. It's certainly not wrong to consider it. I think it's certainly very reasonable to consider, but I think it's also reasonable to consider radiation therapy for improving local control with primary resection.
So how much response do you get with radiation therapy, and without any radiosensitizers? Because we use ifosfamide with radiation. Even low doses of ifosfamide, we've seen 99% necrosis in some of these tumors without neoadjuvant chemotherapy.
I think it depends on the histology. So myxoid liposarcoma is extremely sensitive to radiation therapy.
Absolutely.
I don't think you need chemotherapy for that.
That's right.
Synovial sarcoma, we've seen some responses. I can't say that we've seen 99% necrosis routinely. I have used full dose ifosfamide with radiation therapy in a situation where someone had a very large tumor, and I was worried about the interval development of distant metastatic disease during the 5 weeks of trying to give radiation therapy. But that's a fairly uncommon scenario.
I think the difficulty in general with and why there is so much controversy is that the data's not great. If it was a massive difference, everyone would be doing it, right? It would be no controversy. But the problem is these are very toxic drugs, and they don't have a dramatic change. And so, but it's a difference between age to a large degree. If you have a 45-year-old patient with young kids, they're much more likely to accept significant toxicity to try and have some increased benefit, versus if you have a 78-year-old patient that is more likely to say, you know what, this really toxic drug combination may not be for me. And I always try and frame that with a patient and say, look, here's the data. I can't make a decision for you. This is not osteosarcoma where it's really like a dramatic difference between the two. Yeah. And it's to a large degree because of a judgment call.
Yeah, so it's interesting because we have 4 experts with, 4 different opinions, not so differing, but a different approach, right? Who's right, who's wrong, and then you can take a community oncologist who may only see a handful of sarcoma patients